Great, thanks so much. I'm going to take the next 30 minutes or so talking about the imaging arms race, understanding and quote-unquote winning it. And the way I'm going to kind of package this presentation is three major parts. First, I'm going to talk about the arms. What do I mean when I talk about the imaging arms? I think that's worth defining and kind of elucidating. Next, what is the race? What is the nature of this imaging arms race? And then, of course, lastly, and perhaps most importantly, how do we win? And I'm kind of use that kind of a little bit tongue-in-cheek. But I am intent on winning this race with us. And by winning, it's the patients, the medical healthcare professionals, and clearly society as well. So without further ado or dramatic lead up, the arms I'd like to divide into three major parts. The diagnostic imaging tools, the interventional imaging armamentarium, and then imaging informatics. So in general, most imaging probes or tools, if you will, kind of can be subdivided into three major components. There is the physical probe, there's the tissue attribute of the patient that we're studying, and then the signal detector, if you will. So in this little model right here, the physical probe is the X-rays produced by the X-ray tube. The actual tissue attribute, when you're using X-rays or radiographs, is the patient's density or atomic number or thickness. And lastly, of course, there's the detector, in this case, a film screen in the bottom right here, which can take the image signal from the patient as it interacts with that X-ray probe and create a coherent image of the internal anatomy. Okay, what is an X-ray? I think that's actually worth defining just for a second for those of us who don't remember our high school or maybe college physics. It's actually a bit of a miracle, frankly. You take a wire, you boil electrons off it, you accelerate it towards a heavy metal, in this case tungsten target, and two atomic interactions of that electron with the tungsten molecule, or actually atom, will lead to high energy photons. One, the interactions as they are affected by the pole of the nucleus will cause them to stop or slow down or break. That slowing down will lead to the release of these high energy photons. The other way, and then I won't belabor this, if you knock out an electron from an inner shell, as the outer shell electrons falls down to populate that shell, it too will release energy. Those are the two ways we get the so-called X-rays. Okay, onward. Radiography, still the bread and butter of our imaging service, the most commonly performed test in any radiology department. The probe, X-rays themselves, the tissue property of the patient, density, atomic number, like the atomic number of calcium, for example, is much higher than that of fat or other water elements within the body. And then, of course, the screen film. There are a number of other detection panels, stimulable phosphor plates, five-panel imagers. The bottom line, though, as this child sits there, having the X-rays pass through her elbow, being detected by this film screen system below, will produce beautiful lateral and AP images of the elbow. How about fluoroscopy? Fluoroscopy, X-rays again, there's tissue density properties as well, but unlike the X-ray, it is a visible dynamic image. And certainly a more dynamic experience for the radiologist as well. Here, clad in his lead armor, using the image intensifier, X-ray produced from below, passing through Barney in this case, being picked up by the image intensifier, and lovely dynamic images of the abdomen as it peristalsis. And again, one of the miracles of fluoro, as I think most of us are familiar with, you can put intraluminal contrast, such as barium, allowing us to see the stomach and the proximal jejunal contents as they peristalse to and fro, detecting both normal and abnormal anatomy. Okay, computerized tomography. X-rays again. The probe is X-rays or gamma rays. The property of the tissues, again, density, atomic number, and thickness, but unlike the prior systems that we described, it takes tomographic or slice-like images as the image source, the X-ray source, flashes through the body and picked up by this series of detector arrays. It spins around, creating slices of the patient. And if you give contrast, you have these lovely contrast-enhanced images of the head in the CT-enhanced study of the brain, as well as of the abdomen, for example, outlining the liver, the pancreas, this benign vascular lesion of the right lobe of the liver. And it's actually a relatively pleasant and comfortable experience for the patient as they slide through the gantry. How about nuclear medicine? Nuclear medicine is different. It's fascinating. It is a different beast, though. It's much more molecular and physiologic. Image probe in this particular case is gamma rays emitted from the patient, from the organ, intravenously or sometimes orally. A radiotracer bound to a molecule is administered to the patient. It accumulates in the organ or process of interest. It emits gamma rays, which are then picked up by a sodium iodide crystal. So a patient would lie on this table. The patient, he or she, is the source of the gamma rays, which are then detected by the sodium iodide crystal panel array on the top there. And highly sensitive but frequently non-specific information is acquired. For example, in this image of a young infant with, let's say, leg pain, you see the increased radiotracer uptake up and down that left femoral shaft. In this child with osteomyelitis. The lack of specificity, though, as we know, this could be trauma, it could be a neoplasm as well. It shows increased bone replacement and uptake. It doesn't necessarily specify the distinct pathology. In terms of ultrasound, ultrasound again, completely different now. We've been talking about X-rays, we've been talking about gamma rays. This particular ultrasound, the probe is the reflected ultrasound wave. The properties of the patient are the change in density or elasticity as that ultrasound wave, that sound propagates through the patient's body and is reflected back. We'll talk more about elasticity in just a moment there. And the detector system is that array of piezoelectric, basically kind of that interface between sound vibration and electrical current, which first transmits the ultrasound wave in this case, but then bounces back and is translated from those multiple levels that the sound waves and echoes come back to into a coherent image. An ultrasound is truly a miracle, right? There's a quiet miracle going on in an ultrasound that I'll tell you a little bit more about in just a moment, but extraordinary anatomical information of the internal solid organs and frequently physiologic information. Using that Doppler effect, we can get arterial and venous signal information. You can also see movement. You can see fluid, and you can use it also to guide therapy. And as we all know, no ionizing radiation, so generally regarded as an exceptionally safe and portable means of acquiring anatomic and pathologic information. MRI. MRI is worth an hour-long plus lecture on the physics, but rather than bore you, I will just simply summarize that what we're looking at, what we're listening to, are singing protons. Let me elaborate just a moment on that. Within the body are protons in practically every compartment of your body, in water, in fat, in the marrow space, you name it. The entire trick, if you will, of MRI is you put the body in a very, very strong magnetic field. Those protons will act like little magnetic bars and tend to get aligned. But they're not a static alignment. They will spin. We use the physical term precess, but really it's spinning. The physical analogy that's always been offered is a spinning top or a gyroscope. The extraordinary thing is you can predict the frequency of that spinning top, and if you can use a radio frequency, just a radio wave like you're listening to 107.3 FM or something like that, if you can target the frequency of that radio frequency wave to the exact same frequency as the spinning protons, you can excite them, you can alter them, you can manipulate them, and as they bounce back, they will sing out a radio frequency wave that an antenna can pick up, localize in three-dimensional space, and paint a volumetric picture of the internal anatomy. It is so profoundly impossible to believe that it is impossible. It took about 20 years to get the Nobel Prize for that, because really it's impossible for this to actually work. It's just inconveniently we have daily examples of this actually working. Kind of along the lines of the bumblebee flying. Okay. But what can you do with MRI? Again, the probe itself, what is detected is the radio frequency waves. Yes, we're talking about magnets, but it's the RF or radio frequency pulse that sings back that we detect. The spin relaxation is the property of the body that we detect, and we get it with the coil, and what you get, of course, is these exceptional soft tissue images of the fetus, for example, or the body. You can even, using tricks of physics, follow the motion of blood within the body and map out, without contrast, the tangled web of varices within the body of a patient. Now let's talk about interventional radiology. Spent that first part talking about diagnostic imaging. There's a huge and growing field of interventional radiology, and that's basically using image guidance to alter pathology, to cure disease in certain cases. Within the vascular interventional procedure suite, we can do things like place stents across areas of stenosis in the right renal artery, relieving that stenosis and treating renal vascular hypertension. If there are tumors, either malignant or benign, we can trace out the vessels supplying that tumor, embolize them, put polyvinyl coils or beads, and choke out the blood supply and treat it. Kill the darn thing with only a puncture wound, as opposed to a large open wound and a long recovery period and a hospital stay. Within interventional radiology, that was the vascular. The non-vascular is another huge area of exploration and opportunity. Things like draining fluid collections, whether abscesses or dilated collecting systems, in this child who underwent a bilateral nephrostomy tube position. For biopsies, rather than a large open biopsy with a wound and bleeding and infection and adhesions, you can simply and elegantly pass the needle between the ribs using CT guidance, gather a sample of this tissue for analysis. There is a very exciting host of image-guided therapies, such as radiofrequency ablation. In this particular case, there is a tumor in the right lobe of the liver. A needle is placed that is hollow throughout, which basically these metal tines are extended into the meat of the tumor. Radiofrequency waves are placed through it, heating or cooking that tumor. This is only one example. Any form of energy fatal to tissue can be used. Cryotherapy, cold, laser therapy, and then very, very fascinating, an emerging field called high-intensity focused ultrasound. So earlier I said ultrasound is seen as benign and non-harmful. That is true, but if you focus it along the lines of taking that magnifying glass and focusing the light of the sun on an object, you can burn it. That same principle applies to ultrasound, whereby you can non-invasively cook or burn tissue deep within the body. Lastly, let me talk about imaging informatics within this discussion of the arms. A lot of people equate imaging informatics with PACS, or Picture Archiving and Communication Systems, and I want people to understand is it's not this image. It's not the radiologist sitting at his or her ergonomic table, and you notice a little cup holder here too, I noticed as I was assembling this picture. Must stay well hydrated. It's more than PACS. The promise of the imaging informatics is not just any image, anytime, anywhere. That's certainly a part of it, but it's much richer than that. There's teleradiology, the ability to create the referral of images to worldwide experts around the world and vice versa, and the ability to augment the abilities of the radiologist using computer-aided detection and diagnostic tools. One good way graphically of explaining the complexity and richness of informatics is this diagram here. So here's picture archiving and communication systems, but it's not just viewing, there's post-processing, there's hard copying, filming if necessary, remote viewing, reporting, and on this side the complementary informatics system of the radiology information system. That's the acquisition, that's the reception, that's the archiving, that's the decision, that's the making sure the right report is filed in the right patient's name, the inventory, that rich promise, which to date has not been completely realized, as we all know, of that image properly matched to the patient with the data, as much information extracted from the imaging data set as possible. And then regarding augmenting the ability of the radiologist or other imaging professional, computer-aided detection and diagnosis, such as detecting subtle pulmonary nodules and characterize them or comparing them to prior studies. So in summary, regarding the arms, diagnostic imaging arms consist of the probe, tissue characteristic, and a detection system. Interventional radiology, a rough but pretty good way of dividing them is vascular and non-vascular procedures. And informatics, comprehensive image storage, sharing, post-processing, and assisted diagnosis. Let's turn our attention now to the race. What is the imaging arms race? I'm going to talk about three major categories. One, evolving technology. Then talking about emerging technology, and lastly, medical cost, which is a formidable topic to discuss. Evolution of CT really points out how much things have changed in a very, very short period of time. Our career. When CT was first introduced, you took a pencil beam thick of radiation and you translated across the patient, and then the gantry would flip about 1 degree. You take that pencil beam and go through that entire laborious process, taking minutes per slice, Then someone said, well, shoot, let's create a little fan beam. Let's truncate the amount of times we need to turn that beam. And this dramatically shortened scan time. But then someone even brighter said, hey, let's take that fan beam and make it wide enough to pass through the entire patient's body, and that was born the advent of that helical. Actually, that's not even helical. It just is a nice single rotation rather than multiple translational steps there. Then someone came with the idea of decoupling the imaging source from the power source. It used to be on a tether or a leash. You'd have to hit it, unwind it back, scan, wind it back there. Slip ring technology allowed a continuous rotation because now the energy was supplied directly to the camera via the metal tube or housing, which was the birth of spiral or helical CT. And then you see where this is going. If you can get one spiral, why not 4? Why not 8? Why not 16? Why not 64? We are currently at 320 slices. If that's not a race, I'm not quite sure what is. But the evolution is impressive. The first clinical Mark IV scanner installed in London had these incredibly crude images. It took minutes per slice, and you could barely, if you squint your eyes, see that cyst within the left frontal lobe. But this was a miracle, a non-invasive way of peering inside the skull in a patient, previously impossible to diagnose other than with physical diagnosis. We now, of course, can trace and follow rapid arterial flow and tease out the minute vessels of the head and neck in a patient. Let's talk about, why do we care about speed? In the mid-19th century, among gentlemen who spent their time racing horses, one of the biggest questions is, when a horse runs, do all feet leave the ground at a certain point, or is there always at least one hoof on the ground? We probably don't care a lot about that, but this is a source of much contention, maybe even duels back then. But the problem is you can't tell. So those artists who were bold enough to make a guess frequently showed horses flying through the air like Superman. Those less bold would just show the horse kind of proudly standing there, perhaps arching up like that majestic image of Napoleon on his war horse. Until 1872, Leland Stanford's prize racehorse Oxden galloped across an innovative photographic development and exposure system developed by Edward Muybridge, settling once and for all that when the horse runs, yes indeed, all 4 hooves do leave the ground, although the horse doesn't look like Superman. What's my point? My point obviously isn't that we care about the horse kind of running that way, but there are certain processes that are so fast that unless you have the technology, you cannot understand them. That applies to galloping horses and it applies to certain forms of disease in the human. Evolution of ultrasound. Harmonics, the ability to tease apart very, very hard to see lesions in large or obese patients and now map out precisely their margins. Elastography, the characterization of the pliability of tissues, with neoplasms frequently being harder. Now, using the elasticity of a tissue, you can actually characterize the tumor and characterize its response to therapy. One of my favorite miracles is this handheld ultrasound device. Not too long ago, ultrasound was said, could it be the stethoscope of the future? Well, when there were still big portable units that you can push around and weighed a couple hundred pounds, probably not. But if you can pack it in your belt like an iPod, I would say that this can go anywhere, anytime, anywhere. MRI. This is a huge subject. Summarizing, though, MR angiography, following vessels, diffusion, detecting strokes when they can still be reversed, spectroscopy, actually teasing apart and understanding the metabolites in both normal and abnormal tissue, tracing out the tracks of the white matter fibers, chemical shift, function. We can literally now read people's mind, which is both exciting and scary, right? If you're thinking about a certain thing, areas of your brain will light up. I'll leave that to the ethicists among us to ponder the non-medical applications of that. And therapy. Intraoperative MR. We now have MRIs literally hanging from the ceiling, all 9 tons of this machine, able to slide forward over the brain of a patient undergoing surgery so that any residual tumor nodules can be removed without closing. And interventional MRI. Those techniques that are currently being done in a biplane angio suite could potentially be moved into the MR environment without radiation exposure, which is a big, big deal in the young child. And here's an example of a tumor biopsy using an MR-compatible biopsy system. Let's talk about emerging technology. And what I was talking about today was the extraordinary evolution of some of the imaging that we use every single day. There are some imaging techniques out in the wings in experimental labs and academic centers that may or may not see the light of day. There's something called terahertz image. Incredibly high frequency wave, very poor penetration, but it can literally map out the follicles and molecular characteristics of skin cancers and skin diseases. Here are multiple follicles and a scar right across the upper part of this terahertz scan. Optical imaging using optical light waves, but in the ways that we use CT scans to map out the fovea in this patient. Or thermography. Here's a shoulder that got an injection in the shoulder. It raised the degree temperature about 2 degrees Celsius and a very nice map. What might this do in terms of detection of fever source in a child with an unexplained limp? Molecular imaging. Don't have time to talk about this in depth, but right now most of what we do is anatomic imaging. We're moving into functional or physiologic imaging. One of the great promises in radiology is biologic or molecular imaging. Not saying is it bone, not saying if there's blood flow, saying is there the receptor, is there this gene, is there this extracellular matrix protein. This is an example of gene delivery. Is the gene delivered to this mouse in this particular case because the activation of this gene-specific probe? The answer is yes. This is an example on the bottom left of an antibody-targeted probe. It doesn't say is there blood flow. It says does this breast cancer have the HER2 receptor, which is a big deal in terms of targeting therapy. This mouse model has a tumor that does not have the HER2 receptor. It doesn't enhance. On the other hand, this model on the bottom does. It enhances. This is a tumor without putting a needle in or sampling tissue. You can predict that there will respond to this novel therapy. And then angiogenesis as well. I'm going to play this if it will play. It won't. But that's okay. Really quickly, there are theranostic agents, which are these encapsulated bio or chemotherapeutics that can be surface decorated with antibodies or other ligands. Apologize for that. That will seek out the molecular signature of certain tumors. So rather than creating a lot of collateral damage, as we currently do with many chemo and biotherapeutics, this will deliver it to the tumor, kill the tumor, and spare the surrounding normal tissue. Medical costs. This is the last part of that race there. In 2000 to 2006, it is estimated that the amount of money spent on imaging doubled to $14 billion annually, $14 billion. Going from 2000 to 2008, Massachusetts residents who were privately insured, the amount of money spent on imaging increased 20% to $1.2 billion. Here's the thing. It wasn't all just the increased cost of the technology. Sometimes it was charging more for the exact same technology. And I submit this little graph on the side here, which is kind of eye-raising for us who are studying healthcare costs. How much do you charge for a head CT? Multiple countries, Spain, Netherlands, Germany, France. The winner is Spain at $161 for a head CT. The next highest one, actually the second to the highest one, is Canada at $530. And look at the USA. Average, $950 for a head CT. Average, maximal they found, $1,800. So clearly there is some variability on what you charge for the exact same scan. Hospitals, meanwhile, are in the crunch, right? They need to keep up with technology. Otherwise, they can't attract the best physicians or trainees. But my practical question is, does imaging technology really increase costs? Does it fundamentally increase costs? And here's a counter-argument. When I was in medical school, which is not that long ago, someone with a motor vehicle accident would come in, kind of vague symptoms. I would cut a hole in their belly, pour in saline, drain it out, and count white blood cells, red blood cells in, and look for stool. That was a diagnostic peritoneal lavage. I don't think anyone's done this in a long, long time. Why? Because rapidly, non-invasively, we can look inside, we can see whether or not there are lacerations to the internal organs, and we can decide there and then whether we do or do not need to do an operative procedure. Appendicitis, another great example. When I was training, 25% false positive rate was normal. You go in, right lower quadrant pain, vague symptoms, and it's a normal appendix. Well, 1 out of 4, no problem. It is very, very rare now, working with our surgeons, for this to happen. Why? Because routinely, and I support this, get a diagnostic ultrasound examination. It's no radiation, and skilled hands, the sensitivity is extremely high. And if you see a brawny, enlarged, thick-walled, hyperemic appendix, well, there it is. If it's normal and it's mesenteric adenopathy or some other cause, we will let them know that as well. In summary, the existing imaging technology is truly in an evolutionary race, which is mind-spinning to provide more and different diagnostic information. Then there's the emerging technology in the wings that very well may move from the laboratory to the clinic. Hospitals, as well as physicians, are in a race, though, to keep up with this latest technology while trying desperately to keep costs under control. Lastly, how do we win? How do we win? I'm going to discuss three things briefly. My timer says I'm out of time, but I think I still have 5 minutes. Can I confirm that? Okay, cool. Discuss appropriateness criteria, the high reliability organization, and finally biomedical imaging integration. It is true that imaging is confusing, and deciding what test to do is equally confusing. I'll just share that American College of Radiology is working very hard to develop appropriateness criteria, evidence-based imaging. There's a wealth of information. It honestly just needs to be at the point of ordering at care. It doesn't really help you to know that there are appropriateness criteria if it's on a website or is protected or you need a subscription. So we're working on that. Certain rules are very simple, and yet we don't do a good job of getting them out there. The Ottawa ankle rules. I've yet to meet a radiology resident who knew what these were. Press 4 areas. Can you bear weight? If the answer is there's no pain and you can support yourself, don't get that ankle test, right? I share with pride a study performed at many national children's hospitals, including ours, 2009, saying ask 6 questions. Is the mental status normal? Are there hematomas, loss of consciousness, the severity of injury? And ask mom and dad, hey, is your child doing okay? If the answer is negative to all those, don't do the head CT. The evidence supports you. You don't have to be medical legally worried about that. Cautionary tale, though, right? This is 2 years ago. Who remembers this? U.S. Preventive Service Task Force, a nonpartisan scientific panel analyzed the data and said, hey, we're recommending against routine mammography. Were they supported? Oh my God, these people are so concerned about cost effectiveness. Yay, thank you. They were vilified. They were excoriated. People, patients, physicians, politicians rose to the challenge of making them look as bad as possible. These physicians and scientists were shocked. They had to backpedal so severely. Imagine yourself being just absolutely vilified by Congress people on the television or the subject of ridicule on these political cartoons. Quickly, so its conclusion obviously is not enough to have appropriateness criteria, right? We have to do a better job of educating our public regarding the rationality of being rational. High reliability organization. Radiology is a double-edged sword. None of us will ever recover from an incident that happened in upstate New York, 2001, where a child's head was crushed by an oxygen tank brought in there by accident. The power of this magnetic field is shocking, and if you go on the website, you will be entertained by an endless array of medical devices brought into the field. Everything from wheelchairs to oxygen tanks to gurneys to buffers and even guns. The radiation safety, I don't have time to talk about that. Suffice it to say that there is a statistically valid argument that in a portion of the children we subject to CT scanning, they will get a fatal cancer as a result of that. This extrapolated atomic bomb data. The study will never be done. But if you believe in statistics, there is an up to 1 in 1,000, 1 in 10,000 risk that a young child getting an abdominal CT will contract a fatal cancer. Meanwhile, of course, 2009, Cedars-Sinai Hospital, California, 206 patients over 18 months subjected to over 8 times the normal amount of radiation per head CT because someone played with the settings and forgot to set them back. The concept of the high reliability organization, we try to take lessons. I don't think, despite all we've done in safety, we've made that big a dent. Complex reasons, of course, but the concept of the high reliability organization, which we use in aircraft carriers that have jets flying on and off and a nuclear reactor powering that sub, are valid lessons for us. Preoccupation with failure of all sizes and shape, reluctance to simplify, sensitivity to operations. It matters. Vision is great. Mission is great. Operations need to be addressed as well. Commitment to resilience. People will fail, and we need to recover from that. And a flat as possible hierarchy when it comes to the subject of safety. Really quickly, because I just can't help talking about this simulation really quickly. Think about the task. You're trying to teach a jouster how to joust. You have to ride on this huge stallion. You have to hit a target while avoiding being hit yourself. How are you going to do that without killing them all off, right? What you do is you create a simulator. This is a mannequin on a post that will spin. The target is the shield. The held in this right hand is a mace that will spin around when you hit and try and knock you off your tail. Now, for me, I think I'd still get pretty seriously hurt by this, but clearly a lot better than having galloping you full charge with the lance as well. Military way ahead of us. Flight simulator data. The old flight simulators help pilots get those first 10 missions under their belt so that that first mission was actually the 11th and they'd make it back home. And clearly the extraordinary sophistication of airline industry, jumbo jet simulations, and the rising field of medical simulation to help us deal with complex and variable and stressful procedures that don't happen every day. Let me conclude with a quick discussion on the future of how to work together. There are multiple fields who credibly and validly want to get into the imaging field, and I totally respect that. What we as radiologists need to do is lead the charge in terms of the comprehensive picture. Imaging is not buying a ultrasound scanner and starting to use it up there. There is the scheduling to make sure it's scheduled correctly, that it's appropriate. There's the performance of study in terms of the quality and the safety and the reliability. There's the reporting. What is that permanent record? And there's that consultation function. So what we need to do is provide more value to everyone in terms of these elements that we have put so much time and effort into. Lastly, regarding the quality of turf, we tend to talk about turf wars, and I think the only way really to win this is turf sharing within turf wars. I steal a term from Creston, Guilford Creston in 2009, the Biomedical Imaging Enterprise. And his point is we should now start to think about imaging, since it's so big and so important, as a huge biomedical imaging enterprise, radiology contained within it, but also overlapped by all the clinical specialties that have a mission within imaging too. Orthopods, cardiologists, vascular surgeons. We need to have the best diagnosis, and that's provided by radiologists, with clinical expertise working with clinicians, with imaging expertise, fed by and included by imaging processing, nuclear medicine, and also nurtured by emerging fields such as bioengineering, molecular biology, and medical physics. My summary in terms of winning, which I think we're all invested in, all of us win by making imaging utilization decisions based on appropriateness criteria and based on evidence as much as possible. We also win in terms of safety for staff and patients by creating a high reliable organization that is committed to patient safety. And lastly, we win in terms of the entire healthcare enterprise by organizing biomedical imaging to optimize workflow, maximize technology utilization, and minimizing any turf battles between radiologists and clinical imaging subspecialists. So with that, I thank you very much for your time. Thank you very much.